somewhere in your medicine cabinet or your bag right now, there is something that chemically overrides one of the most powerful biological drives your body has ever evolved. And most people couldn't explain how it does that if their life depended on it. We are going to break down the real science, the actual biology, the hormonal pathways, the feedback loops, the mechanisms that make contraception work at such a fundamental level. And I promise you, by the end of this video, you are going to look at birth control in a completely different way. Let us start at the very beginning, because to understand how birth control works, you first need to understand how pregnancy happens in the first place. Every month, inside a female reproductive system, something remarkable occurs. The brain begins sending out a chemical signal, a hormone called gonadotropin-releasing hormone, or GnRH. This signal travels from a part of the brain called the hypothalamus down to the pituitary gland, which sits just below it. The pituitary gland receives this signal and responds by releasing two more hormones, follicle-stimulating hormone, known as FSH, and luteinizing hormone, known as LH. FSH does exactly what its name suggests. It stimulates follicles inside the ovaries. These follicles are tiny sacs that each contain an immature egg. As FSH rises, several follicles start developing, but typically only one becomes dominant and continues maturing. As that dominant follicle grows, it begins producing estrogen. Estrogen levels in the bloodstream climb steadily throughout the first half of the menstrual cycle. Here is where it gets fascinating. High estrogen levels eventually send a signal back to the pituitary gland in what scientists call a positive feedback loop. Normally, hormones work through negative feedback, meaning high levels of a hormone suppress further production. But in this case, high estrogen actually triggers a massive surge of LH. This LH surge is the trigger. Within roughly 36 hours of that surge, the dominant follicle ruptures and releases the mature egg. That is ovulation. The egg then travels down the fallopian tube toward the uterus. If sperm are present and one successfully penetrates the egg, fertilization occurs. The resulting fertilized egg, called a zygote, continues traveling toward the uterus, dividing and developing along the way. Meanwhile, the follicle that released the egg transforms into a structure called the corpus luteum, which begins producing progesterone. Progesterone thickens the uterine lining, making it rich and receptive for implantation. If the fertilized egg implants successfully, pregnancy begins. Now you understand the system, and now you can understand exactly how birth control disrupts it. The most widely used form of hormonal birth control is the combined oral contraceptive pill. Combined means it contains two synthetic hormones, a synthetic estrogen and a synthetic progestogen, which is a progesterone-like compound. These pills work through multiple layers of interference, which is part of why they are so effective. The primary mechanism is suppression of ovulation. Remember that LH surge that triggers the release of an egg? Synthetic hormones in the pill essentially convince the hypothalamus and pituitary gland that the body is already in a high hormone state. Because those feedback loops are being artificially maintained, the pituitary never sends out the FSH and LH surge needed for ovulation. No LH surge means no follicle rupture. No follicle rupture means no egg is released. Without an egg, there is simply nothing to fertilize. But the pill does not stop there. Even if ovulation somehow occurred, synthetic progesterone causes the cervical mucus to thicken significantly. Cervical mucus normally changes throughout the cycle, becoming thin and slippery around ovulation to help sperm travel easily. On the pill, that mucus remains thick and hostile to sperm, creating a physical barrier that is incredibly difficult for sperm to penetrate. There is a third mechanism as well. The synthetic hormones alter the uterine lining itself, making it thinner and less hospitable. Even in the unlikely scenario where fertilization occurred, implantation would be far more difficult. This multi-layered approach is what gives combined oral contraceptives their very high effectiveness rate when used correctly. Now, let us talk about the progestin-only pill, sometimes called the mini pill. This one works a bit differently. It does not reliably suppress ovulation in all users, though it does in some. Its primary mechanisms are that thickening of cervical mucus and that thinning of the uterine lining. Because ovulation suppression is not guaranteed, timing is more critical with the mini pill. It must be taken at roughly the same time each day to maintain effective cervical mucus changes. Moving beyond pills, let us talk about long-acting reversible contraceptives, because these are where the science gets really interesting. Hormonal IUDs, small T-shaped devices placed inside the uterus by a healthcare provider, release a progestogen called levonorgestrel directly into the uterine cavity. This localized delivery is a significant advantage. Because the hormone is released right where it is needed, the doses are much smaller than what you find in pills, yet the effect on cervical mucus and the uterine lining is very strong. Many users find that their periods become significantly lighter or stop altogether because the uterine lining is kept so thin that there is little tissue to shed each month. Then there's the copper IUD, which is fascinating because it works without any hormones at all. Copper ions are toxic to sperm. The copper continuously released from the device creates an environment inside the uterus that impairs sperm motility and viability. Sperm that enter that environment become unable to swim effectively or to survive long enough to reach an egg. The copper IUD is also one of the most effective emergency contraceptive options available because if placed within 5 days of unprotected sex, it can prevent implantation even if fertilization has already occurred. Hormonal implants are another remarkable technology. A small, flexible rod about the size of a matchstick is inserted under the skin of the upper arm. Over 3 years, it slowly and continuously releases a progestogen called etonogestrel. The steady release creates a consistent hormonal environment that suppresses ovulation much more reliably than the mini pill does. This consistency is actually one reason implants have such high effectiveness rates. Hormonal injections, the most well-known being the shot given every 3 months, work similarly by maintaining a continuous progestogen presence in the body that suppresses ovulation and alters cervical mucus. Now, let us talk about something that many people wonder about, but few fully understand, which is the science of how birth control affects the body beyond contraception. Estrogen plays a role in bone density. During a natural cycle, estrogen helps maintain bone mineral density. Some forms of birth control, particularly the 3-month injection, which can lower estrogen levels significantly, have been associated with temporary decreases in bone density in some users. However, research generally shows that this effect reverses after stopping use. There is also meaningful research on how hormonal contraceptives can affect mood. This is a topic that deserves respect and honest discussion. Progesterone receptors exist throughout the brain, and synthetic progestogens interact with those receptors. Studies have found associations between hormonal contraceptive use and changes in mood for some individuals, including increased risk of depression in certain groups, particularly adolescents. The science here is genuinely complex because different progestogens have different molecular structures and interact with receptors in slightly different ways. Some bind primarily to progesterone receptors. Others also interact with androgen receptors or glucocorticoid receptors, and those different binding profiles can have different neurological effects. It is worth noting that many users report no mood changes at all, and some even report improvements in mood, particularly those who experience severe premenstrual symptoms. The interaction between synthetic hormones and individual brain chemistry varies enormously from person to person, which is why your experience may be completely different from someone else's. Let us also talk about the cardiovascular effects, because this is an area where the science is important to understand. Combined hormonal contraceptives, those containing synthetic estrogen, have a small but real association with increased risk of blood clots, technically called venous thromboembolism. Estrogen affects clotting factors in the blood, making clotting slightly more likely. For most healthy, non-smoking women under 35, this risk is very small in absolute terms. But for people who already have certain risk factors, including being a smoker, having a history of migraines with aura, or having known clotting disorders, the risk profile changes considerably. This is precisely why healthcare providers screen patients carefully before prescribing combined hormonal contraceptives. Progestin-only methods do not carry this same cardiovascular concern, which is why they are often recommended for people who cannot safely use estrogen-containing contraceptives. Now let us go back to something foundational, because understanding effectiveness requires understanding the difference between perfect use and typical use. Perfect use means taking or using contraception exactly as directed, every single time, with no errors. Typical use reflects real-world conditions, where people occasionally forget pills, take them at inconsistent times, or use methods imperfectly. Combined oral contraceptives have a perfect use failure rate of less than 1% per year, meaning fewer than 1 in 100 people using them perfectly will become pregnant in a year. But with typical use, that number rises to around 7 to 9%. Long-acting methods like IUDs and implants have the same effectiveness under both perfect and typical use, because there is no daily action required, no room for human error in the same way. This distinction matters enormously for anyone trying to make informed choices about contraception. One more piece of fascinating biology worth discussing is the concept of emergency contraception and how it differs mechanically from regular contraception. Levonorgestrel emergency contraceptive pills, the type available over the counter in many countries, work primarily by delaying or inhibiting ovulation. They need to be taken as soon as possible after unprotected sex, because their effectiveness is highest before the LH surge occurs. If taken before ovulation, they prevent it. If taken after ovulation has already occurred, they are unlikely to prevent pregnancy, because fertilization may already have happened, and levonorgestrel does not reliably prevent implantation, despite what older packaging used to suggest. Ulipristal acetate, available by prescription in many places, is a different type of emergency contraceptive that works by blocking progesterone receptors. It is effective later in the cycle and can delay ovulation even closer to the time of the LH surge, giving it a slightly longer effective window. Understanding the mechanism matters here because it helps set realistic expectations about when and how these options work. The human body's reproductive system is an extraordinarily precise biological machine, and hormonal contraceptives work by inserting themselves into that precision, mimicking signals, disrupting feedback loops, and altering the physical environment in ways that are backed by decades of scientific research. That is not to say there are no trade-offs. Every medical intervention involves weighing benefits against potential risks, and birth control is no different. What the science tells us is that for most people, these methods are safe, effective, and well understood. And for everyone, the decision deserves to be based on accurate, complete information rather than fear or confusion. The more you understand your own biology, the better equipped you are to have informed conversations with your healthcare provider, to ask better questions, and to make choices that are genuinely right for your body and your life. If this video helped clarify something you have been wondering about, consider sharing it with someone who might benefit from understanding this topic more deeply. The conversation about reproductive health should be grounded in real science, and the more we talk about it openly and accurately, the better off we all are. Leave a comment below telling me what you found most surprising, because I genuinely want to know what resonated with you